Hello, everyone, and welcome. I'm Marcia Mott, the Health Promotions Coordinator for UF Health. Welcome to the Wellness University webinar. September is Prostate Cancer Awareness Month, and we have an incredible lineup of speakers who will share information about the latest advances in diagnosing and treating prostate cancer. Thank you for your patience today as we deal with the hurricane on the way and allowing us to make this a little more flexible. Our first speaker today is going to be Jasmine Brown. Jasmine is a physician assistant specializing in urology. She graduated from the University of Florida Physician Assistant Program and joined UF Health about 1 year ago. She's originally from Maryland and loves Maryland crabs. She chose urology because she's passionate about reducing health disparities, and she really enjoys caring for both men and women as her patients in her practice. Our second speaker is Dr. Wayne Brisbane. He received his undergraduate degree in biology from the Seattle Pacific University and his medical degree from Loma Linda University School of Medicine. He then completed an internship in general surgery and a residency in urology at the University of Washington. He went on to complete his fellowship in urologic oncology at UCLA, focusing on the diagnosis and treatment of prostate cancer. His research includes advanced prostate cancer imaging with micro, ultrasound, MRI, PSMA PET scans. Dr. Brisbane is particularly interested in using advanced imaging to guide prostate cancer focal therapy. Here at UF Health, Dr. Brisbane specializes in prostate cancer diagnosis and treatment, and he's also involved in multiple clinical trials, including new treatment energies for prostate cancer focal therapy, such as the NanoKnife, HIFU, and cryoablation. These treatment options are only available through a handful of urological programs in the country. If you have questions for our speakers today, you can submit your written questions at any time using the Q&A button at the bottom of the screen. At the end of the presentation, I will ask the questions that you've submitted. This webinar is also being recorded today, so in about a week, I will send you a link out to the recording in case you want to refer back to it or share it with someone who couldn't attend today. So Jasmine, I'm going to go ahead and turn it over to you now. Thank you so much.
All right, good afternoon, everyone. Let me just make this bigger.
Yeah, and we hear you just fine.
All right, perfect. So today we'll be dispelling the myths about prostate cancer screening and treatment. I'm going to do the first part of this presentation, kind of going over what is the prostate, what is prostate cancer, and different diagnostic tools that we have. And then Dr. Brisbane will take over with more diagnostic tools and then treatment. So a lot of individuals, the first question they have is, what is the prostate? It's a gland that's about walnut sized. It's found in males. It kind of sits underneath the bladder, wraps around the urethra, and it does have an important function to males that I'll talk about a little bit later. In this diagram, you can just see that the prostate is kind of situated in between the bladder, and then for the males, wraps around the urethra, and then the urethra is just a tube which urine exits the body. The function of the prostate, so it produces this prostatic fluid that's important to the function of sperm. It makes up a portion of the ejaculate, and then it's basically just essential for reproduction and male fertility. What is prostate cancer? So prostate cancer is one of the most common malignancies in males. Approximately 12% of men will be diagnosed with prostate cancer in their lifetime. So if you have 9 men in a room, one of them will get the diagnosis of prostate cancer. And it's the second leading cause of cancer-related death in US men. So usually when someone is diagnosed with prostate cancer, it's going to be in men greater than 65, but it can occur in men at the age of 40 and up. Most men that are diagnosed with prostate cancer, they aren't having any symptoms at the time of diagnosis. If the cancer is advanced or in a later stage of progression, then the men might experience bone pain. And they also might have urination symptoms such as urgency, frequency, having difficulty emptying or decreased amount. Who is at risk for prostate cancer? So there's 3 points. Usually if there's a family history of prostate cancer, African American or African history, and age greater than 40 to 50. As far as family history of prostate cancer, having a first-degree relative with prostate cancer puts an individual more at risk, so siblings or father. And then also if family member was diagnosed at a younger age, which less than 65, then that individual has an increased risk of prostate cancer, but also earlier onset. For African ancestry, unfortunately, Black men are more likely to be diagnosed with prostate cancer, more likely to be diagnosed at an earlier age, more likely to have an advanced or more aggressive type of prostate cancer at diagnosis, and are more likely to die from prostate cancer. For the age, it's rare in men less than 40 years of age. More than 90% of men are diagnosed greater than 50. The median age in the US is about 66. So when we do prostate cancer screening, we look at a few things. The first thing is the health history, which I kind of touched on in the previous slide, the PSA, and then digital rectal exam. So the health history is when the individual comes in and we ask the questions such as, do you have a family history of prostate cancer, your fathers, your siblings? And then we kind of also stretch to see if maybe on the maternal side or grandparents, because that also counts. We ask them if they have any personal history of cancer. We ask if they're African American, and we definitely have to pay attention to the increased risk, and then of course age as well. As far as the age-wise, we usually start screening around 55 to 60, and then AUA guidelines say that you can stop screening. It's a shared decision-making at age 70. So what is the PSA? I feel that a lot of individuals, when they hear PSA, they automatically get concerned, but it's actually a normal protein that's produced by the prostate. It actually leads to greater sperm movement, which is important for fertilization or reproduction. And the PSA blood test just measures the amount of PSA that's in circulation in the body. An elevation in PSA can be influenced by a few things. So if your prostate is large, which the prostate kind of naturally grows with a man's age, and they'll get bigger and bigger prostates. So you can see the elevation with that. And of course, you can see it with prostate cancer. If a man has a urinary tract infection or prostatitis, you could also see an elevation in PSA. If there's any kind of prostate manipulation, such as in the office here, we do a cystoscopy, which is a procedure. If the person uses a catheter, if we've done a prostatic massage, a recent biopsy, or even just like bicycling, or anything that kind of puts extra pressure on the perineum, kind of sitting down for an extended amount of times, things like that. Ejaculation or recent sexual encounter can elevate the PSA, and then, as I stated earlier, increase in age. So the digital rectal exam, we perform it in conjunction with the PSA. So we do the digital rectal exam and the PSA once a year. During the exam, the reason why the DRE is so important is because we can put the finger on the prostate and actually feel if there's any abnormalities. So things that we look for would be any hardness, just any abnormal texture of the prostate that is concerning. So then we have further diagnostic tools that we offer if someone comes in and they have an elevated PSA. These are some of the next steps that we may have. And that includes the 4K, the ExoDx, the prostate MRI, and then prostate biopsies. So I'll start off with 4K. So the 4K is a blood test. It incorporates a few things. So it takes into account the PSA, the patient's age. We did a rectal exam, what's the findings, and then if they ever had a prior biopsy, that also is incorporated in. And it predicts the risk of significant prostate cancer. The higher score you have, the higher the risk that the patient will have prostate cancer. And then it also predicts the risk of the cancer spreading, or if you hear the word metastasis. The ExoDx is a urine test, and it kind of evaluates the 3 genes that are associated with the increased risk of prostate cancer. And then the higher the score also indicates the higher risk of prostate cancer. And then for imaging modalities, a lot of time with the prostate MRI, the next step after an elevated PSA can be the 4K or the ExoDx that I discussed earlier, or we could go ahead and get imaging. The imaging, it can determine if there's a need for a prostate biopsy in men with an abnormal PSA. It basically can tell us how the size of the prostate, exactly how many grams or cc's the prostate is, and then it tells us if there's a lesion that we can target on the biopsy, which is going to be really important for the next step of the talk with Dr. Brisbane. And I think I will let him take over.
Okay, can you hear me okay?
Yeah, we hear you just fine.
Great. So thanks everyone for this opportunity. And it was a really nice talk by Jasmine, who is the best PA at University of Florida. So really a treat for both of us to come and chat with you. She's talking a little bit about prostate screening, and I'm going to talk about the actual diagnosis and then treatment options. And the diagnosis at this point is made with prostate biopsy. So we'll chat a little bit about that and then kind of how that helps risk stratify patients and then what we do going on from there. So I'm going to do a little bit of drawing, which is important. So let me get teed up for that. And okay, that's working beautifully. Okay, so Jasmine showed you a picture from the front of the prostate. And I'm going to show it to you from the side just to kind of orient you. So this is going to be, oh, just a second. Am I going to have to touch this each time? Maybe. All right. So this is going to be from the side. And so this is the pubic bone. That wasn't in her picture, but the pubic bone is kind of, a lot of you know where the pubic bone is. This is the abdominal wall going down to the pubic bone. Your belt buckle would sit right about there. And then this is the phallus. Glands, penis right there, scrotum, perineum, rectum, gluteal muscles, and then the back. And so this is opening you like a book and then looking at you from the side. The prostate sits right behind this pubic bone right there. The bladder sits on top of the prostate. And then there's a tube that goes through the prostate like that called the urethra. The rectum goes in close like that and then kind of attaches to the rest of the intestines up here. And then the spine is like that. And this is the sacrum. The sacrum is, this is your sit bone right there. And then there's a muscle hammock that goes from the sacrum all the way over to the pubis. And that holds everything in, suspends all your organs, and is also important for fecal and urinary incontinence. And then something we're going to draw that will be important later is there's some kind of telephone wires that come out of the spine right here, go along the prostate, and then plug into the penis. And those are the kind of the telephone wires for an erection going from the brain to the phallus. It doesn't affect like orgasm or desire, but it's just the hydraulics of an erection to go from the flaccid to the erect state. And so all of those things have been drawn many times better by Dr. Netter, who is a very famous kind of medical illustrator. And so you can see all the same things, this pubic bone right here, the bladder, the prostate, the rectum. These are the muscle fibers going through right there, testicles, perineum, same thing. And we're specifically focusing on this organ right here. This is the prostate with the urethra and ejaculatory ducts going through it. Just as Jasmine said, we're kind of mentioned the prostate is right underneath the bladder. And so you go out into the world here. The prostate has a lot of different sizes to it, and it grows over time. So this is kind of age here on the x-axis, 10 through 80, and then this is the size in grams. And so when you're very, very young, your prostate's very, very small, about the size of a dime when you're born, and it slowly grows until you hit puberty, and then it goes under exponential growth in your 20s and 30s. And then in your 30s to 40s, it kind of has this plateau. And then, as a lot of men will tell you, in your 40s, your prostate just kind of starts misbehaving. And it's one of those organs that just continues to grow. And we don't know everything about why this happens, but it's a common misconception that prostate growth is related to cancer. It's not necessarily true. The growth actually is happening at two different parts. So the cancer is happening, for the most part, in the peripheral gland, the peripheral zone. And if you were to go back here, you can see, well, that peripheral zone is occurring right through this area. And so that's why when we do a digital rectal exam and we feel the prostate, we can feel a good portion, if not all, of the area of the prostates that is responsible for cancer. And so that's why the digital rectal exam, despite all of our new technology, remains an important part. And it's a good way to stage the cancer too. You can see if it's growing out of the prostate, and we'll talk about that in a little bit. So this is the peripheral gland, it's the gland tissue. This is what is responsible for what Jasmine was talking to you about, producing the seminal fluid, and it's also the part that can get into trouble with cancer. The BPH portion, or the part that's responsible for the urinary portion, very, very rarely creates cancer, but it's like this little donut that's restricting the urinary flow right through there. And that's what causes urinary symptoms. So just an important thing to know that there are two different zones. The prostate as a gland will cause both urinary issues and prostate cancer, but not necessarily at the same time. And oftentimes men who have prostate cancer may not know it, and men who have urinary issues may not have prostate cancer. So these are those nerves that I talked about that come down. You can see that they're extremely close to the prostate, and actually some prostate cancers will use the nerves as a ladder to crawl out. So that's one of the things that you can see, that any treatment that involves the prostate is going to involve one of three areas, right? It's going to involve the rectum because it's very close to the rectum. It's going to involve the bladder because it's very close to the bladder. And it will involve these erectile fibers or nerves that go from the spine around the prostate and then plug into the penis. I've drawn these kind of like a wispy, spidery web thing because that's really what they are. It's not a distinctive nerve. These are autonomic nerve fibers, so they're very, very thin, kind of like dental floss, and they're bundled together and run in a lattice along the prostate. So it's not a definitive nerve. When we say nerve sparing and stuff like that, it's important to know that these are kind of a lattice, and so you can do a partial nerve spare, even though that seems silly. And we'll talk a little bit about that here in a moment. So as Jasmine was saying, PSA is a normal protein. It is produced by the body. It can go up for multiple different reasons. One of them is prostate size, prostate manipulation. But if you have a cancer that's growing here, which I represented by this red dot, that is going to kind of elbow the normal tissue and cause your prostate, or cause one's prostate to leak PSA. And that can be detected on prostate cancer or on a blood test, and is an indicator of prostate cancer. And so that's important. That's why we use this test as a screening mechanism to say, hey, is there anything going on in the prostate? Because only the prostate produces PSA. It's also why PSA is a great biomarker after treatment. And so we'll talk about that a little bit. So one of the first things we have to do is we have many, many different forms of imaging, micro ultrasound, MRI, we're going to get to, but the basis of prostate biopsy is still a basis of diagnosis is still a biopsy. Because as you'll know here in a little bit, not all prostate cancers are the same. They look very different under the microscope, and how they look under the microscope really helps us figure out exactly how the cancer needs to be treated. So what we do is we're going to either have a biopsy that goes through the rectum or through the perineum. And this is, we'll get to that imaging here in a second. And that's going to take a little piece of the prostate cancer and show it to a pathologist to tell us, is it cancer, A or B? And then if it is cancer, what type of cancer is it? And we'll go over that in a moment. This is a really good and exciting time to talk about some of the research we're doing at the University of Florida. This is conventional ultrasound. It's the ultrasound machine that you would get if you went to most places. And you can see that it's good. You can see these anatomic structures that we talked about. This is the peripheral zone in the smiley face shape. And this is the peripheral zone, this is the peripheral zone. This is the transition zone that we talked about, and the urethra runs right through the middle here. So here's a really good example of how these areas are anatomically distinct. The rectum would be facing right here. So you can see if you put a finger right there, you'd feel a good portion of this peripheral zone, but not so much this transition zone. And then the urethra runs right through the middle. Let me draw a couple of these structures for you. The urethra is going to run right through the middle. And so if there's an enlargement down here in the peripheral zone, that's not as concerning as if there is an enlargement circumferentially here in the transition zone. But an important thing about micro ultrasound or conventional ultrasound is that it's invisible. The cancer is invisible. We can't tell the difference between the normal tissue and cancer tissue. On micro ultrasound, cancer has a very distinctive shape. It kind of, you can see this border. There's a little bit of a difference in the, we call it echogenicity, or how dark the cancer is, but oftentimes on micro ultrasound, we can see it. And so with a combination of micro ultrasound and MRI, we're doing the biopsies at the University of Florida and achieving really, really accurate results. And that's important to get a very accurate result to start, so that the cancer we have, we've described it well, and we can get you the appropriate treatment, not just a treatment. So this is what the biopsy looks like when it comes out of the gun. It looks like a little pencil lead, and this section will have kind of gone through a cancer like that. So you're going to have a little core that the pathologist is looking at. And the pathologist is going to say, okay, well, this is what a normal gland looks like. So they're looking at these glands all through here, and they're saying, this is what a normal gland looks like. And this is the structure. There's these cells that are oriented in roughly like big circles. And the purpose of these cells are that they take blood and nutrients that are derived from the blood that's circulating through your system, and it transforms them into proteins and minerals that the sperm can use for insemination. One of those is PSA. That's, like Jasmine said, it just helps the sperm be able to swim for insemination. Another important feature is that there's a basal membrane. So this basal membrane is important. It helps these cells be oriented. It helps them push the nutrients and PSA and all the other proteins they make in the correct orientation. And it just is one of the main features of benign tissue, meaning non-cancerous tissue. If one of the important things that we can chat about if we have some more time is the food source, which I've drawn as a blue arrow here. The food source for all prostate cells, cancer and benign, so it doesn't matter. If you're a prostate cell, your food source is testosterone. And that's like the gas pedal for all of these cells. The brake pedal for all of these cells is something called a tumor suppressor gene. A very, very well-known one is P53. There's many others. And basically, there's a very kind of delicate balance for growth and kind of suppression of growth, or if you think about it simply, gas pedal and brake pedal, in order to keep these cells growing at a healthy rate. If one of these things breaks, either the gas pedal becomes too sensitive or the brake pedal fails, what you can do is you start having increased growth relative to work, okay? And if that really starts to break down, the internal glands outpace the kind of extracellular membrane. They're saying, well, we just want to grow. We don't care about you working, doing much work. And uncontrolled growth is actually the basis of cancer. That's really at its most infant or easiest to understand form. Just unregulated growth is what cancer is. And if these cancers, you can see they almost look like these glands, just very small kind of non-functional forms. If they start crowding together and forming these clusters, that would be even worse. And if they don't form glands at all, right, these are just little cells packed together as fast as they can go, that would be even worse. And you can see, if you were making blood and nutrients, or taking blood and nutrients and transforming it into PSA, well, yeah, the PSA would go nicely outside of the prostate in this situation, and pretty well outside of the prostate in this situation, and okay outside of the prostate here. But once you get to these stages, any PSA that's made is not going to find its way through this labyrinth. It's just going to leak right into the blood. And so that's how we detect that there's some kind of cancer growth in the prostate, by noticing that there's PSA leakage. So what we've also done is there's a grading scale. It's called the Gleason score. And this Gleason score assigns a score to each one of these different kind of morphologies or the way that these cells look under the microscope. And so we say this is 1, which is normal. 2 is a variation of normal, as long as this basal membrane is still intact. Once the cells lose that basal membrane, they go into 3. And so this is why Gleason 3+3, which starts at 6, is the first style of cancer. This is the first style where you get where you're starting to lose that basement membrane. And then this is pattern 4 and then 5. So we would do, for example, let's say in this section right here, there was majority 3 and a little bit of pattern 4. The pathologist would say, well, this is a 3+4 cancer. And you can imagine any combination of this is possible. We don't usually report 1s and 2s because those are just reported out as benign or normal. But you could have 3 plus 4, which if you had 4 plus 3, you might see occasionally. Excuse me. So if you had 4 plus 3, that would be equal to 7, just like 3 plus 4 was equal to 7, but it would be not as good because it would mean the majority of the pattern was pattern 4, because whatever's the majority goes there. And so that's how you can have 3 plus 4, 4 plus 3, but you can have 4 plus 4, 4 plus 5, 5 plus 4, all these different patterns of cancer, which would obviously, as the more of these higher numbers you get, the more aggressive those tumors tend to be. Now, it's important, we actually had a question in the chat box that I got to a little earlier. And the question was, well, why is it that some people or some physicians recommend watching these cancers rather than treatment right away? Well, it's because not all prostate cancer is the same. In fact, it behaves very, very different. One of the things that is a big driver of behavior is Gleason score, and that's that 3 plus 4 all the way through. We have to put these into a risk bucket. And one of the things we use is Gleason score. So the 3 plus 3 goes into the low risk bucket. 3 plus 4 and 4 plus 3 go into the intermediate risk bucket. And anything greater than 4 plus 4 goes into the high risk bucket. There are other risk buckets, but I think for simplicity, 3, as far as low, intermediate, and high, is the easiest. There is a very low and a very high risk. But I think that for the most part, these 3 risk buckets do a great job of kind of describing the field of cancer. The other thing we use is PSA. How leaky is the PSA? So if your level is less than 10, that goes into the low risk bucket, 10 to 20 intermediate, greater than 20 is high. Stage has to do with when we feel the prostate cancer. If we were to stick a finger in here and try and feel down here at the rectum, do we feel anything? If no, we call that T1, meaning tumor stage 1, and that would be completely inside. That'd be low risk. If we can feel a little bump, that would be T2, intermediate. And if we can feel the cancer starting to crawl through the capsule, that would be T3, and that's high risk. So these are those buckets that I was talking about. In general, we treat each of these buckets a little bit differently, okay? So if you're in the low risk bucket, these are the individuals where we often recommend active surveillance. Sorry about that. Intermediate risk has a lot of treatment options, and high risk has a lot of treatment options as well. But I think this is an important pivot, and this is what probably is going to differentiate you from a lot of your friends and family who hear prostate cancer and immediately group all the diseases together. Now you have the ability, which is important because it's 1 in 9 men getting prostate cancer, to know that there's very distinct risk categories that prostate cancer has to sit in, and all treatment decisions kind of spiral out from whatever risk bucket you or your loved one get placed into. And so that's really important. Now, the treatment paradigm that we're trying to achieve is cancer cure with minimal side effects. And you could see the prostate is at the crossroads of several organ systems. Gastrointestinal, right by the rectum. Reproductive, it's obviously part of the reproductive system by producing the sperm, and it is involved in the nerves that, it's geographically very close to those nerves, and then urinary. And so any kind of treatment in that area is going to have repercussions on all 3 organ systems. And this is the goal. You know, as we have a balance between cancer control, we want to have also balance the length and quality of life, okay? And it's important to know that as a whole, cancer or prostate cancer is a generally very well-behaved prostate or cancer. The high-risk cancers do kill people. In fact, almost 30,000 men a year. So it's important to know that high-risk cancers are aggressive. However, if you take all prostate cancer together as a whole, it tends to be reasonably well-behaved. And so it's important to try and balance quality of life with cancer control. These are 4 very important trials. We don't need to go through them in detail, but they all have long follow-up showing that cancer control, in the lower risk cancers, oftentimes it takes a very long time before you notice any benefits from treatment. And so that's just to kind of prime the pump and say it's very important when you're talking to and choosing an oncologist that you find someone who really appreciates this balance. So I've outlined here in general, these are the strategies, and there are caveats to each one of these. But in general, we recommend active surveillance is the preferred mechanism or the preferred therapy for low risk cancers. The reason for that is several of the studies that I demonstrated above did not show very much benefit, a little bit, but not necessarily very much benefit to treatment of low risk prostate cancer. And you saw that these trials at least had 10 years of follow-up. And so what you can be assured of is if you're in this low risk bucket, your risk of death from prostate cancer within 10 years is pretty low. Occasionally we'll have very high volume, and 3+3 means that, you know, the entire prostate's 3+3, and we'll do some genetic markers to help risk stratify. But as a general take home, low risk prostate cancer is extremely well behaved, and active surveillance is a very reasonable preferred approach for people who are in this bucket. At the University of Florida, we do a couple things for active surveillance. That looks like that's going to be a PSA every 6 months, more or less, an MRI every 18 months, and then a biopsy every 3 years. We kind of titrate the biopsy based on if your PSA starts to go up, if a new lesion pops up on MRI. We're using a couple of, we're doing a little bit of research on finding some better biomarkers, meaning better indicators of when a cancer might be turning from a 3+3 to a 3+4. But in general, we try and be careful not to do too much because it can be a long wait. If you get diagnosed in your 60s and you live till you're 85, that's 25 years of surveillance. That's a long time. So we try and keep the surveillance as gentle as possible, but still prevent any reclassifications, is what they're called. So if this 3+3 turns into 3+4, that's what we want to find and make sure that we're monitoring that successfully. So that's active surveillance in a nutshell. The others, for intermediate risk, there's surgery, radiation, and focal therapy, which we're going to talk about pretty extensively. And then for high risk cancer, there's combination therapy. And we can talk about this to some extent, but this is often individuals who need either surgery followed by radiation followed by intensive hormone therapy, sometimes even surgery with hormone therapy, surgery and radiation together in some clinical trials, and then radiation with chemotherapy in a lot of settings. So these are going to be individuals who need multimodal therapy, a lot of combination. Thankfully, not a ton of men get this high-risk prostate cancer. I do think that if you do have high-risk prostate cancer, it's worth talking to one of our urologic oncologists. We're happy to provide that phone number. There was one individual also who talked about radiation followed by a recurrence. And so this is the disease site group where you're more likely to get a recurrence. And so salvage therapy comes in as well. And we are happy to chat about that. But let's focus our attention, just for the purpose of this talk, on surgery, radiation, and focal therapy for the intermediate risk person, because those are they tend to be a little bit more common. So this is just reorienting us to our anatomy. This is going to be our lesion, and I'm going to talk about the focal therapy first. So first, let me just draw this in. So for focal therapy, what we do is we try and take one of these, we try and isolate the lesion first, and then we're going to take a needle and we're going to put a needle into the lesion, okay? Once we've been able to put a needle into the lesion, just like we did with biopsy, we can do a couple of things. We can radiate it, we can freeze it, or we can pass an electrical energy through it. It doesn't really matter. All of this is designed to treat the cancer and try and do as minimal damage to collateral structures as possible. So that's the idea of focal therapy. Now with focal therapy, there's very few risks to the bladder. There's very few risks to the rectum, but there's still some treatment effect that go to these nerves. So you'll notice that it tends to be gentler on people than maybe surgery. Radiation in this disease group actually is pretty gentle on people's erections, but what you will notice with, or at least the selling point for focal therapy, is that we're able to treat the cancer and provide minimal collateral damage. So that's the goal of focal therapy. What I tell people is that is true. I consider focal therapy kind of active surveillance with a hammer. If you have 3+4 in low enough volumes and you're interested in doing very little collateral damage, one of the things we can do is we can go in with a needle, ablate the tumor, and then do active surveillance to the rest of the prostate. I think that this is a very nice strategy for some individuals. The caveat is that the cancer can come back in any of these other locations. So we could have a cancer that comes back over here. Additionally, some of these cancers have little tentacles, and those tentacles can extend beyond our margin, and then those cancers will come back over here. Now, as long as we monitor you carefully, that's okay, because these cancers still tend to grow very slowly. So even if we miss a little area over here, or if it has a tentacle, that area will grow pretty slowly. But if you do focal therapy, you need to be willing, or at least mentally okay, with recurrences being a possibility in the future, because they're more than likely going to happen at some point in the future. But the nice part about focal therapy is it's very minimally invasive. It has a low side effect profile, especially if done by an experienced provider. And it's, as long as you're monitored, it appears to be extremely safe from a cancer perspective. There's a group from Europe that just published their 15-year experience with the maximum result of about, or the maximum follow-up of about 8 years. And they found that there was about a 30% recurrence rate at around that 8-ish year mark. They probably are more optimistic than some, but overall, I think it's a reasonable endpoint to say, you know, about 1 in 3 to 1 in 2 men are going to have some recurrence over that 5 to 10 year period. And I'm happy to answer any questions. As you might have noticed, identifying these other little areas outside the prostate is extremely important. I kind of glossed over some of the energy systems, like there's many out there: HIFU, NanoKnife, TULSA-PRO, steam therapy, gold nanoparticle. And I'm happy to chat individually with anyone about these. I think all the energy delivery sources are less important than the actual localization of cancer. Once you localize cancer and do it accurately, then you can use whatever energy source you like to destroy the cancer. And I have my preferences. But I really think that the most important thing is the localized staging. And that's what gets into our research here at the University of Florida, where we're using multiple different imaging modalities in order to create a composite treatment model. So we're using microultrasound, multiparametric MRI, and PSMA within the same patient in order to really make sure that the cancer is right here. And designing this composite treatment model, you can see how close those nerves, these are the nerves in yellow, get to that red area, which is the cancer. But very reasonable to say, well, this guy only has cancer right here. So if we're doing surgery, we would say, well, it's not safe to spare that nerve because it's probably being used by the cancer as an escape hatch. But this nerve is just fine. Or if we're doing focal therapy, just knowing that we're able to treat down along here with the margin. And then we also have some collaborative trials with our team, both here at the University of Florida, Gainesville, and at the Proton Center, where they're using their proton beams or photon beams under MRI guidance to boost this area, just give it a little more dosage. Okay, so I think that the imaging is very important, both for focal therapy and for whole gland therapy. As far as surgery, what we do is going to be, for surgery, we do a robotic approach. So the robot goes in through this area, and we use these little robotic arms to go around underneath the bladder. There's a couple of approaches. Obviously, if you were tasked with taking the prostate out, you could make an incision right here along the bladder neck and an incision right here and take the prostate out that way. We do have to do that for men who have a little bit higher risk cancers. I prefer not to, though, if I can get away with it. So what we've been doing is this thing called a Retzius sparing approach. The Retzius sparing approach instead takes the robot and it goes from behind the prostate So we go around this way and we take the prostate and we make an incision here. But you can see that there's some muscle fibers right here. And I think that those well, actually, it's been very well described that these muscle fibers seem to be very, very important as far as preserving urinary continence or preventing urinary leakage. And so what we'll do is we'll carve the prostate kind of going this way and then remove the prostate that way. This will help preserve urinary continence, and then this area will be this area right here will get sewn down to this area right here, which really helps with preserving this nice muscle bundle, which helps with making sure men don't leak after radical prostatectomy. The radical prostatectomy, that is one of the side effects, is the urinary leakage, and you can see why. If you disrupt these muscle fibers up top here especially, you can have urinary leakage. In a good majority of men, I'll tell you, will have to wear pads for the first couple of weeks, and then will rapidly kind of regain their urinary continence, especially if you use a technique like a Retzius spare or a hood technique, which is very similar. So you just want to ask your surgeon when they're kind of talking to you about surgery, or you or a loved one, what are the techniques, what is their experience, and what are their results with those techniques. Obviously, sparing these nerves is safe in some conditions and not in others. So for example, here, when we made this composite treatment model for this guy, sparing this nerve would mean sparing the cancer as well. So we were able to spare this nerve for him very nicely, but this nerve we decided not to spare. So we went around the cancer through that nerve, and he had a good cancer result and still was able to have erections because of the use of this nerve. We also have a treatment program here led by Dr. Kevin Campbell, who's one of my partners, called a sexual prehabilitation program, where we try and get these nerves working to their best possible capacity, both before and after surgery. So that involves some sexual prehabilitation using Cialis, Viagra, a penile pump, which sounds hilarious, but it works very well. And he has a nice protocol and some very good outcomes where we're helping men kind of achieve their sexual function back after surgery. So that's, in general, the basics of surgery. Again, urinary leakage is a main thing. And then the sexual function, obviously, if these nerves are right adjacent to the cancer, it's not safe to spare them. The rectum is thankfully usually very safe. We're able to dissect that away from the prostate during surgery. And so that's one of the areas that doesn't get as much traditional treatment during the surgical approach. The other thing that can sometimes be taken out is the lymph nodes, which act as little filters. And the lymph nodes usually sit a little kind of around up here. And so these lymph nodes act as filters for prostate cancer. And so those will be taken out as well, occasionally, dependent on the risk profile for this cancer. So I'm going to keep on going just in interest of time. So this is the slide that I'm going to talk about radiation. If you do radiation, radiation is a big topic. It's very complicated, but I'm going to give you the basics of it. There's two ways to deliver radiation. One is that you can implant things within the prostate and they can glow from the inside out. This would be your seeds or brachytherapy. I think of it, if you take a bunch of Christmas lights and you balled them all up, they would kind of glow from the inside out. And so that's brachytherapy. And it's a very good treatment. And if you're doing brachytherapy, I can answer some specifics about exactly what you're looking for. But in general, what you'd get is you'd get radiation, which would kind of create a halo around the prostate like this. And that would be glowing from the inside out to treat the area of the prostate. Now, as you might see, you would be getting treatment to the bladder, a little bit of treatment to those nerves and the penis, occasionally, depending on kind of how wide the field was. And then you can also get a little bit of treatment to the rectum. So that feels kind of like a sunburn in the bladder. Urgency, frequency tends to resolve within a couple of months, maybe around 6. You can have a decrease in erectile function, but again, these nerves are still functional. They're still working, but they just are getting a little bit of radiation and maybe a little bit of radiation to the arteries that come in and supply the penis. So you do get a decrease in the erectile function after radiation, but it's just not to the same extent as surgery. Surgery is a little harder on erections. because you can't leave the nerves in place if the cancer is invading them. Not true with radiation. You're able to kind of bathe the radiation around those nerves. The nerves can still function, allow the electrical energy to go down to the penis with still maintaining a good cancer cure, is what I'm trying to say. And then you can also get some radiation effects on the rectum. That's important. That can cause some fecal urgency and issues with kind of fecal incontinence very rarely, and it oftentimes resolves. Now they have a very nice technology where they're able to put a spacer, it's called, or there's a couple different kind of names for it. I'm doing this thing. It looks like a little unicorn pen. So this is very, very magical. But basically what you do is you put this little hydrogel down in there, and that hydrogel is able to push the rectum away so the radiation hits the gel instead of the rectum. And so that is a very nice technology that I think is becoming very standard of care. So you should definitely inquire if your radiation oncologist will offer that. And then ours do here at the University of Florida. So that would be brachytherapy, radiation coming from kind of the inside out. The same idea happens with traditional photon therapy. So if it's traditional photon therapy, what's happening is there's, photon beams that are going from multiple different angles. So, they're like, why do we have to go get photon radiation all so many days? It's because they only want to give you a little dose on multiple days. They don't want to just, give you the single dose all at once. And so what you'll see is, as all these beams of radiation come in from multiple different angles, they all cross at the prostate. And so the tissue out here gets not too much radiation, but the tissue at the middle where it crosses gets the majority of radiation. And they do a much better job of filling in the dots than I do. So that's the idea of photon. The same side effect profile as brachytherapy. Some would argue maybe a little bit more bladder and rectal treatment because the beams have to come in and cross through those, so they get a little bit more heat. But I think that in general, similar side effect profile is a fine generalization. As many of you may have heard, we have proton therapy here. It's a great center. Nancy Mendenhall is an absolute jewel. She has created a very, very exciting proton center. In general, she'll probably hate me to say this, but in general, I would say that the comparative studies between regular radiation and proton radiation have not shown considerable benefit. I will tell you that our proton center is specialer and better than all the other proton centers. But it is the national comparative studies haven't shown a huge benefit. So I don't think you have to get proton center radiation in order to get an excellent result. And I'll tell you that the University of Florida in Gainesville just installed an MRI guided radiation or linear accelerator. So the radiation, instead of being guided by CT, which is kind of coarse and not as good at fine tissue delineation, the radiation is delivered by an MRI. And I think that is a huge, huge step forward. I'm very impressed with the technology. I think Bob Zoltecki and Kate Hitchcock have really achieved amazing results with that technology. So anyway, but the idea behind proton is that the beam comes in. So you have this proton beam that comes in and then it stops in the prostate. And so you get, it almost has like a little reaction and it kind of degrades. And so you have these beams come in and this part of the beam is not as damaging as the little thermal nuclear detonation that happens in there. So you get these little areas right there. In general, though, they still have to cover the same areas. They still have the same kind of collateral damage. They still have the same kind of urinary, rectal, erectile issues. So I would say, regardless of what type of radiation, it's less important. What I would say is really important for your treatment is if you're going to do focal therapy, get somebody who is extremely experienced, really does a lot of focal therapy. If you're going to do surgery, get a very experienced surgeon who does a lot of surgery and really thinks and is careful about it. If you do radiation oncology, get somebody who's very, very careful, does a lot of it, and has good results. And we'd be happy to, if, for example, if it's a long way for you to travel to the University of Florida, I do a lot of consultations with people who either by video visit or they come in for our first consultation. We chat about what I think is the best treatment for them. And then we find treatment for them, actually the daily treatment closer to home. So that is my last slide here. Thank you. Awesome. All right, Marcia, I've talked all I can talk.
Well, you're in luck then, because we have some great questions for you that have been submitted.
Great.
Um,
So I answered a few others. I'll briefly recap. One was I'm just going to close this for a second. One was, that question I mentioned, why would you ever watch prostate cancer? That seems crazy. And that has to do with this, if you're in this low risk bucket, these studies specifically SBCG4, Pivot, and Protect, all showed that treatment of lower risk prostate cancer does not necessarily extend quality of life, or if it does, it extends quality of life greater than 10, length of life. It doesn't extend length of life within 10 years. So what you really need to get benefits in treatment in your 60s if you're going to, and then it'll pay you in your 80s, that kind of thing. So prostate cancer is a slower growing disease, especially if you have this low risk stuff. This high risk stuff is a different animal. And so nobody or very few people, unless you're treating somebody who's going to almost die from something else in the next year or two, or I guess 5, nobody would suggest watching this high risk stuff. This intermediate risk stuff is a little bit more complicated balance. But in general, for intermediate, you want to have at least a 10-year life expectancy. And so that would be your mid-70s, is because our national average is about 86. And so it's obviously different if you're a marathon runner or very healthy, or if you have a lot of comorbid complications or other cancers on board. But in general, it's about 10 years to get treated for this intermediate risk stuff. The second question I had was a gentleman who had proton radiation, which is fantastic, but then started having some complications. And the complications of radiation, I think, are very important to talk about. You can have complications of surgery, which you talked about, which would be leakage, erectile dysfunction, but you kind of are done after that, which is a nice thing about surgery. After surgery, you tend to get all your side effects up front and you slowly get better. After radiation, you tend to get a gentler set of side effects, and you sometimes get these nastier side effects that come back later. One of them is secondary malignancies. And so this radiation can cause cancers. It's extremely rare. It's extremely rare. And I want everyone to hear me on this. Do not think that you don't do radiation because of the risk of secondary malignancies. But if you start having symptoms of secondary malignancies, we will really, really need to check on that. So you can get secondary cancers from radiation, specifically blood-based cancers like lymphoma, leukemia, and bladder cancers as well, and some pelvic sarcomas. So if you have any blood in your urine, that is a mandate to come and see the urologist. Do not hesitate. Please come and see us. And you can basically just type in University of Florida Urology, and there is a phone number to call, and we should get you in right away. The next thing that I'm going to see here, so we have 66-year-old male with a family history of prostate cancer, had a low PSA each time a UF medicine family doc had checked it. I'm going to see if I can, I don't know how I can, maybe you should pitch these to me so people don't see the names.
66-year-old male with no family history of prostate cancer, low PSA each time his doctor has checked it. The last few years, she said, and the rectal exam and the PSA are not indicated every year in my annual physical. Do you still agree with that? How often would you suggest a PSA or an exam? Also, is there any usefulness for men to learn to do a self-exam like is recommended for testicles?
Yeah, good question. So I would say that the annual screening is there. Your primary care doctor is not wrong. There's a lot of conflicting data on how often this should be done. I do recommend it every year until you're 70 at least, and then there's some debate. I think 75. Once you hit 75, it's very reasonable to discontinue screening, but I would continue it until you're 70 at the very least. And there is a lot of debate about this, but urologists tend to come on it's just easier to do annual surveillance. If you ever have a PSA above 3, I will offer men an MRI. If you have a PSA above 4, I do think that's concerning. And I think the digital rectal exam in the appropriate hands is useful, but I don't push my luck on that. I know that digital rectal exam is not fun for the patient or the providers who are doing them, and urologists do them quite a bit, and so we get very good at them. Primary care doctors have their own opinions on how useful they are. So I would say, at the very least, just get your PSA every year. As long as it's less than 3, it should be fine. You should know that the normal values are around 1. So, if you're not around 1, there should be, your eyebrows at least should go up. We draw a 3 as a line in the sand because that seemed to work really well for the Swedes on their PSA studies. And we use 4 here in the US because that's what we use in the PCLO trial. But I think 3 is actually a better biomarker endpoint, and some people say even lower. So just know that normal is around 1, and you're welcome to get an evaluation by a urologist at any point.
Okay. I don't know if you need to keep using your screen share or not, but if you want, you can. If you don't need it, you can turn it off.
Sounds good.
You might have kind of touched upon this a little bit, but this is a person who wrote in that said that I'm a man that's 82 with a Gleason score of 4 + 3, and then they put in parentheses 1 core. Overall good health. Have treatment, no treatment. And I know that's a really, there's so many things to consider and discuss, and you can't give recommendations, but maybe you could just kind of talk about this, where they know what they have with their Gleason score and how they go about making those decisions.
Yeah. So I would say that in your 80s, you're in a spot where prostate cancer probably can't help you or can't hurt you anymore. Again, not supposed to give recommendations, but I'd be very, very hesitant to do anything that's going to hurt you. Now, everyone will say not every 80 is equal, right? If you say you're in good health, that's awesome. But are you expecting to live till you're 100? Then maybe some treatment is possible. 4 + 3, 1 core, if that's an image guided core versus a systematic core, does make a difference to me. And then how much of the cancer, if the cancer core length, meaning that how much was looked at, was 1 millimeter of 4 + 3, that's a lot less concerning to me than it was 15, 20 millimeters of it. And then your PSA is also important because that gives me another barometer of how much disease there is. But in general, the American Urological Association would not necessarily recommend it because your predicted longevity is till 86. And so if that's it, you're not going to live more than 5 years, then probably not going to be helpful. Any treatment's just going to get in your way.
Okay, thank you. Another person wrote in a question that said if someone is 72, has an elevated PSA around 10, but a normal biopsy, what do you recommend for next screening steps or next steps in that?
Yeah, good question. So this gets into the thing of, PSA can go up for other reasons. And what are we going to do when the PSA is elevated, but the biopsy is negative? And we have a couple tricks. One is we can do some imaging, and we have, like we said, 3 different imaging modalities: MRI, PSMA, and microultrasound. PSMA can be a little bit tricky to get in the elevated PSA MRI negative setting, but we've definitely done it before. If you haven't had imaging, I would strongly suggest it. If imaging consistently comes back negative, but our clinical suspicion is high, we do these as a transperineal biopsy rather than transrectal. I think that's more accurate. And so I would recommend a transperineal biopsy. And then finally, we have used other urinary biomarkers. So Jasmine recommended ExoDx. I think that's a good one. There's 4K scores, but PSA is not the only urinary biomarker. There's others. And if you haven't obtained one of those, I'd also recommend that.
Okay, I don't have any more questions in the chat now. I'm going to go ahead and let that stay open for a minute if anybody wants to submit anything. But I did have kind of one question, and this is more a question for Jasmine, really. As a person who listens to several different prostate cancer talks, we don't talk often about what urology does for women and what kind of things that they might treat in clinic there. And I know that's unrelated, but I know you mentioned that you really enjoyed being able to care for men and women. I wonder if you could just take a minute to talk about that really quick.
Yeah, so actually the two main focuses, I do general urology, but I also help Dr. Brisbane with prostate cancer and some kidney cancer. But then my other focus is urogynecology, which is more of the focus on pelvic disorders for women. I know when everyone hears the word urology, they automatically think men, especially like sexual health, but women, they'll have disorders of like pelvic prolapse, which is increased in women who've had like multiple vaginal childbirths. We kind of work with them for that. We work with urinary incontinence or leakage for women that they have, and we have medications that we can put them on. We do pelvic floor physical therapy. There's surgical interventions that we offer. So definitely want to say that we are more than happy to see our female patients. I work with Dr. Moy and then Dr. Dimchuk, and they both are urogynecology specialists.
Okay. I don't really have any other questions, but I did want to let people know that we are recording this. It'll take me about a week or so, especially depending on the storm, to get that link out to everybody. But we do post them on our YouTube channel, and that's where I'll be sharing it from. So thank you everyone for joining us today. Thank you for taking time out of your busy schedules. I hope everybody stays safe and is prepared, and hopefully we just get a lot of rain, and I'm wishing you all a good day. Thank you.